Thank you. I always have the first speech after the bigger speaker, so thank you for this. Now, in the talk today, I've been asked to give a little bit of an update on vamorolone and givinostat, and I know that is a quite difficult and delicate topic for most of you in this room. So what I try to do is to just try to give you the information about what we know about this drug, which possibly and hopefully will explain a little bit some of the approaches that have been implemented in clinic. And then I was pleased to say that we will have a little bit of time at the end for some questions. So it's my same disclosure that yesterday. So I start with vamorolone, also because it was the first drug that was approved for Duchenne muscular dystrophy in the UK. It was approved in December 2024 and is now implemented into clinic, which means that we can prescribe vamorolone in our clinical practice. I always start to say that vamorolone is a corticosteroid. And you can hear different way to present it. Is a dissociative corticosteroid, is a synthetic new corticosteroid, but is a corticosteroid. But the aim of vamorolone and why it was developed was try to retain the benefit of traditional corticosteroid that are what we usually prescribe, prednisone or deflazacort, but reduce the side effects profile. And the reason behind that is because we know that corticosteroid in Duchenne muscular dystrophy, they work, they delay the natural course of the condition, but they are associated with horrible side effects. So the first principle was if we can remove or reduce the side effects is already a win. So the evidence that we know, and I apologize because some of these I've already presented last year, but I just wanted to briefly refresh them and to know that the evidence that we know about vamorolone predominantly come from these two studies. One is a phase 2b study, was placebo control, and compare vamorolone, 2 doses of vamorolone, 6 milligrams and 2 milligrams versus prednisone administered daily and placebo over a 24 weeks period of time. And then all patients that were enrolled in this study and in other study with vamorolone, the phase 2a study, were enrolled in the long-term extension study where everybody was treated with vamorolone at different doses depending on when they joined the study for a long period of time. And the data that we have from these studies are up to 30 months after exposure. All boys enrolled started at the beginning, so they started on vamorolone. They were not taking other corticosteroid before, so we do not have data on what happened when we switch from traditional corticosteroid to vamorolone. And the second thing is that prednisone is probably one of the oldest drugs that we use, definitely oldest corticosteroid, and we have been using prednisone and deflazacort for many, many years. So we know a lot about these two drugs. With vamorolone, there is a lot of uncertainty because the maximum data that we have is small group, 46 patients, in 30 months. So, and then we assume and we try to extrapolate what it means. What we know so far, that they have similar effect to traditional corticosteroid administered daily up to 24 weeks. And when we compare what we call the natural history, so put in all the data from two large cohorts, one is the natural history of the synergy and one is the North Star, that probably most of your boys contributed to create the data from the North Star. When we put all this data together and we compare to the boys that are on vamorolone, we show that they seem to perform relatively similar in all outcome measures. So how long does it take you to get up from the floor? How long does it take you to walk 10 meters? And this is similar because we cannot compare one boy to another. Unfortunately, we do not have 2 copies of every single boy and say this is what happened if I do this and this is what happened what I do this. So it's a trend and we say they have a similar efficacy. We also know that when we compare 2 doses, 6 milligrams, 2 milligrams, the 6 milligram is better than 2 milligrams, means that they have more benefit of muscle strength and function. But the real aim of vamorolone has never been to be better than classic corticosteroid, was to have better side effects. And what the study has shown is that it's definitely better on one side effects. Clearly, that is this one. This is the height. So, and it's clearly that the blue one are the ones that are on traditional vamorolone, and the orange one are the ones that are on traditional corticosteroid. And you can say that the growth is just a slowdown, so they remain small when they are on deflazacort or on prednisone, and we all know this. And this effect, we don't see that in vamorolone. So they continue to grow as expected for any child. The other positive effect seems to be on bone, and I think that I presented already this data, and there are some update on this. It seems that vamorolone is associated with a less negative effect on bone, means that the bone is less weak. But it's important to notice that it doesn't mean that it doesn't have any effect on bone. So it's reduced the risk of vertebral fracture, but it still has a higher risk of vertebral fracture compared to boys who do not take corticosteroid at all. And also seems that once you have a vertebral fracture on vamorolone, actually, unfortunately, the risk to have a multiple vertebral fracture is very similar to classic corticosteroid. So it is better, but it's not bone sparing. But unfortunately, failed two big tasks that we had and we wanted to. But what the studies show is that actually the effect on weight gain is very similar to traditional corticosteroid. We have strong data that compare vamorolone to prednisone, and they seems to have a very similar effect. We don't have very strong data to compare vamorolone to deflazacort. So when they ask me, is it worse than deflazacort on weight gain, we do not have strong data, but there is this possibility. And the other important point is that vamorolone is still associated with adrenal suppression. So the concept of having the corticosteroid sick dose is still critical for patient on vamorolone, as it is for patient on prednisone or deflazacort. All of these is summarized in the guidance, so just are available on the Duchenne UK website and the DMD Care website, and it's just to try to summarize the key point on vamorolone. And what we try our best to do is to have a table that compare the three corticosteroid. But if you can see here, there are some data that we have, and then on the second page there is not available, not available, not available. And the reason is because we only have data on vamorolone for 30 months, and some of these side effects take longer to manifest. So we still need to learn. So key point can only be prescribed above the age of 4. We are not allowed to prescribe in younger children. Is only in a liquid solution, so there are some children that prefer the liquid and some children who do not like the liquid, but that is the limitation. Has only be tested daily. So we do not have any data in administering vamorolone in a different way, and therefore we do not prescribe it differently. The recommended dose is 6 milligrams, but there is a cutoff that is the 240 milligrams per day. Is similar to what we do with prednisone and deflazacort. So also with prednisone, we prescribe maximum 30 milligrams per day. Deflazacort 36 milligrams per day, and vamorolone is 240 milligrams. Unfortunately, we cannot say that is an equivalent. So 30 milligrams of prednisone is equal to 36 of deflazacort. Yes, but is 240 milligrams the same as 30 milligrams of prednisone? We do not know from a biology. So the general recommendation from a clinical point of view as part of the Duchenne Care UK guidance is that vamorolone might be considered the best option for younger children. And this is because it's where we have robust data, and this is also because it's where we think we give them the chance to grow, and we know how much a low height can impact self-esteem and confidence, and we feel that even if we lose a little bit in terms of strength, that is an important point. But we need to always have a discussion. There are some families that are happy to take the risk of unknown, and some families say, no, I prefer to have the certainties, and it's okay. It's absolutely fine. The other thing is about switching. The one that has been on corticosteroid for a long time, prednisone, deflazacort, should we switch, should not switch? The reality is that is a case by case, and we need to discuss, and it is a joint decision. We do not have data, or we have a very, very limited data that are emerging now from the real world practice. So you need to consider what is important for that boy. Is growing a very important thing, so we might want to try. He's already went through the maximum growth that we can expect, so what is the real benefit? Is bone a concern for the family? We can consider it. Is weight the main concern? What is the point? So we really need to tailor on an individual case. And we do not have data on vamorolone in older one, maybe that are already lost the ambulation, or in adults. And this can be a very difficult decision, but always want to remember that the two greatest benefits are growth and bone. So in an adult that has already used that growth window, what do we expect vamorolone to do? If someone has already multiple vertebral fracture, what do we expect vamorolone to do? And I think that is always a question of managing expectation. Two key points: cause adrenal suppression. I don't want to go to the detail, they are all in the guidance, but if we if we switch from classic corticosteroid to vamorolone, there is a potential risk of adrenal suppression symptoms, which means that the boy start to feel a little bit weaker and feel tired and feel fatigue. Please be alerted about this, report them to the neuromuscular team, because something must be done for that. And we always have the clear recommendation that when we start vamorolone or switch with vamorolone, they need to have hydrocortisone to cover that potential adrenal suppression. All clinician has the protocol how to do it, are in the guidance, I don't want to bet, but you need to know there is that potential risk, be alerted. And the second thing that maybe has been a little bit discussed, but not too much, is that a big word is a mineral corticoid antagonist. What does it mean? The key message here is that has a little bit a different impact on another receptor, which can cause to a dysregulation in electrolytes, so the salts that we have in our body, and can potentially increase the potassium level or the sodium level in our bodies. That can be risky. Normally, this does not happen. But when there are other situations that can trigger this problem, like diarrhea and vomiting, is something that we need to be careful about. And we might need to monitor these blood tests in order to check that everything is fine, or whether the boys need more hydration. And the other thing is that there is a potential limit that it might interact with other drugs that are mineral corticoid antagonists. And some of you know very well, because it's a Plerenone or spironolactone. So far, they have a very small number of boys who have been treated with vamorolone and a Plerenone or spironolactone. They have not been raised any concern, but it's something that we need to be aware and monitor. There is some uncertainty, and then is how we manage it. More data will come from vamorolone in the upcoming years. And there is a lot going on in terms of trying to use the data we already have in order to compare. We are looking into, the company is looking into the boys that have been receiving vamorolone as part of the trial now for 6, 7, 8 years, and how do they look like. There are studies ongoing in younger and older, so the evidence will increase, and we will continue to update, and therefore you probably will hear me talking about vamorolone more and more. I move on now to givinostat, and then I think that we have the question at the end. So givinostat. Very brief introduction about what it is an histone deacetylase inhibitor. Again, another big word, givinostat. The point is, what does it do? At the end of the day, it doesn't do anything with dystrophin, first thing, but it's just to act to the consequences of the lack of dystrophin in muscle, and just allow the expression of other genes that aim to reduce the inflammation, reduce the replacement from muscle to fibrotic tissues, and try to regenerate, have a better regeneration of the muscle. As you all know, givinostat has been granted MHRA marketing authorization in December 2024, and the marketing authorization is very broad, is for everyone age 6 and above. Then it's going now through the NICE process about the reimbursement, and is still pending. We are waiting some feedback soon, but I've been saying soon for so many weeks that I don't know if I should still say soon, but I think that we are expecting a feedback from NICE. So at the moment, we cannot prescribe givinostat in clinic through the NHS. We can do it through an early access program following the MHRA approval. I really want to focus about what do we know about givinostat, and this really try to be as neutral as I can. Okay. The evidence of givinostat, similar to vamorolone, come predominantly from the EPIDIS study, which is a phase 3 study where boys were treated either with givinostat or with placebo over an 18-month period of time, so a year and a half. And after that, they were all moved to an open label extension study. The open label extension study, similar to vamorolone, also brought in additional boys that were enrolled initially in a phase 2A study. And these are the two studies that are informing us about what do we know about givinostat in Duchenne. Important to notice that the EPID study, that is the stronger evidence on givinostat, and is the study that led to the approval of givinostat by the MHRA, enrolled approximately 180 boys, only 120 treated with givinostat and the other treated with placebo. They were all young boys by inclusion criteria, so age 6 and above, but they needed to be ambulant, and clearly ambulant, because they needed to be able to get up from the floor in less than 10 seconds. Also, they needed to be on a stable corticosteroid regimen for at least 6 months before starting givinostat, and they needed to have a stable cardiac function that was defined as normal left ventricular ejection fraction, normal echo, and normal rhythm, to simplify. What did the study show in terms of benefit? So this is a breaking through. It's the first clinical trial in Duchenne muscular dystrophy that is not a corticosteroid that show a benefit. And I think that we need to recognize an emotional impact. How many years we spent in presenting trials that fail to achieve the primary endpoint? Many. And this is the first good news. And there is a objective evaluation of the data, and there is an emotional part to say, wow, finally we have one drug that works in Duchenne. So what that study has shown, that givinostat actually slowed down the disease progression, so they met the primary endpoint of time to climb 4 steps after 18 months. The good thing is that, yes, they use this primary endpoint, time to climb 4 steps, but actually the results were very consistent regardless what we measure. So they were very similar results using the North Star, that is the one on that side, but also on the time to rise from the floor, on the time to rise to run 10 meters. So whatever measure we used, they showed that there was a positive effect. But I always want also to point it out that it took 18 months to show that difference. And if the study would have been designed differently and designed for 12 months, we would be here to present a completely different story, and there's another study that failed to reach primary endpoint. Okay, so the effect is there, but what is shown is that it slowed down. If you look at that picture, unfortunately, all boys in the study got worse over 18 months, as we expect in Duchenne, but the one treated with givinostat slowed down less than the one that received placebo. There are emerging data, and it's been just recently published, on also the OLE, so the data on when everybody received givinostat. And this, you need to be careful when you read a scientific publication, because it's complicated. It took me a while to say, okay, which one there? So these are boys that have been exposed in the open label extension study for an average of 18 months. Some of them received the drug only for 18 months. Some of them that were enrolled in the original study received the drug for up to 8 years. But when they say, oh, exposed up to 8 years, it doesn't mean that everyone that contributed to the result was exposed for so long. And then they compare with the natural history data, that is the synergy, which unfortunately is good because it's global, it's big numbers, but has some limitation because it's an old study, and everybody's on different corticosteroid regimens. But what they show is that actually it seems not only to change outcome measure, but also delay key motor milestones. Here I want to put the effort on the age of loss to rise on the floor. These are not patient by patient. It's not like the result before when I have a patient and I know exactly the trajectory. This is a statistical calculation when you assume what is supposed to happen. And what I wanted to point out is if you look here, these are the numbers that compare is the control group versus givinostat, 142, 142. Not massive, but still good. When we look into how they change, they lose the ability to rise from the floor, the number become much smaller. And therefore, you have 2 people in the wrong group, and then they completely drive that trajectory. So are less strong data, but again are consistent. So they see this for the time to rise from the floor, from the time to run 10 meters, and potentially to lose the ambulation. So the overall impression is that delay key motor milestones. But I think that when people start to put off 2 years, 3 years, 5 years, 7 years, I think that is a little bit speculative. That is what I want to say. Safety profile. So side effects, the most common side effects that are the data from the placebo control, and is a little bit a revision to simplify the message. But the most common side effects, and I hope that you all know, is the reduction in the platelets. What does it mean? Have low platelets mean that you have an increased risk to have a bleeding. That can be a nose bleeding, not big drama, but can also be that if you have a cut, you don't actually heal from that cut and you continue to bleed. To the most extreme, that you bleed inside your body and you don't realize. But that is the extreme that has never been seen. But also means that you might have some abnormality in your skins. That is because the little vessel in your skin are bleeding and you have little red spot on your skin. Okay. But it's a severe condition, so having very low level of platelets can be serious. Also have increased triglycerides. We all know what this means because it's the diet and the potential risk of abdominal problem, the pancreatitis, or about cardiovascular risk. And then diarrhea or abdominal symptoms, vomit, abdominal pain and discomfort. Overall, happen relatively frequently. Is about 1/3 of the boys in the clinical trial develop one of these side effects. But only a minority of the boys in the trial in 18 months discontinued the drug because of side effects, but about 1/3 have to reduce the dose due to side effects. And here I go to the dose. And I know that I make it complicated, and I try to simplify as much as well, but I think that is something that you need to know. The clinical trial has 3 doses, and we used to call dose A, dose B, dose C. And then the dose was based on the weight, okay? So it wasn't one dose for everyone. As I mentioned, the MHRA has approved the drug based on this study. So what they've done is to take these doses. So this is the SMPC is how the MHRA is recommended to prescribe the drug. And we have 3 doses that this time we call full dose, first dose modification, second dose modification. But are comparable, are not identical, because if you see there are many less weight band than here, but are comparable. So full dose, dose A, first dose modification, dose B, second dose modification, dose C. I want to point it out because the reality is that when they did the clinical trial, after the first 50 patients were enrolled in the clinical trial, they look at the safety. That is a normal process because we don't want to enroll 200 patients when it's not safe. And what they notice is about 50 to 60% of the boys enrolled at the dose A develop side effects for which they require the dose reduction. So the study protocol was modified, and dose A was removed from the study protocol, and everybody else was enrolled in dose B or in dose C. And the ongoing clinical trial with givinostat, the Ulysses, or the one in the younger one, only include dose B and dose C. Does dose A work better than dose B and better than dose C? We do not know, because the reality is that only a very small number, so less than 20 boys, have been treated for 18 months on dose A throughout the study. And therefore, it was impossible to really compare the effect of the 3 doses. Okay. There is a tendency to say that dose B is better than dose C, but are just trends because we don't have enough people in each group to say which one is better. Okay. But we know that generally for drug, more you take, better it is. But we cannot quantify this, and we don't have this data. So, based on what we know, we, as part of the Duchenne Care UK project, we have developed a protocol or national guidance that include inclusion-exclusion criteria, the contraindication, and special warning or precaution. We provide information about which dose should we use, how do we modify the dose in response of adverse event, what we know about the drug interaction, when do we need to stop the drug, and then what to do in particular circumstances. Why do we need this national guidance? I think that has been a long discussion, took a while to set them up, but it's important. It stimulated the peer discussion. And when I think about the peer discussion, it's really discussion among clinicians to say, let's look at this scientific data and what do we make out of it? And let's talk, how do you interpret this? How do you evaluate this? But also, we thought it was important to make sure to support the clinician who might have less experience with givinostat. Givinostat so far has always been prescribed in clinical trial. So inevitably, the clinician who have been involved in the clinical trial know givinostat more than the clinician who had never used givinostat. And we thought that was important, that support. But it's also important to be consistent in what we do in order to learn. If everybody does different things, how do we will ever know the safety, the long-term safety and efficacy profile of givinostat? So we need to try to harmonize and learn from what the data tell us. But it's also, we felt, and I hope that you agree, that was important for families to feel that there was a consensus on what to do. And you don't start to say, I follow up in Manchester, I take the high dose, and follow up in Newcastle, I take the middle dose, in Birmingham, it's another dose, and what is the criteria? So we felt that was important to define some guidance, but with the knowledge that the evidence to support this are very limited. So we might be wrong. Before arriving to the conclusion, I just wanted to talk about the elephant in the room. Some of you might not know, and therefore this become a little bit of a bomb, but I thought that was important to put it there. At the end of last year, there been autumn last year, there been a big news in a sense. We were informed of 3 cases of sudden death in young children and young adults with Duchenne treated with givinostat. And these were children and young adults either taking givinostat in routine clinical practice or in clinical trial. And obviously, it's never good news when you hear that. And there was the company, as expected, always they make an assessment. They need to look what happened, and they reach the conclusion that there was no association between these cases of death and givinostat. Then there's been a lot of discussion around. One point that I want to reassure is that by law, the company has to submit the safety data to the MHRA for an evaluation and for assessment. And this is ongoing. The MHRA has met, is reviewing all the data, and we are expecting feedback from the MHRA about what an independent body think about this relationship, and we are looking into that. But the group of the Duchenne Care UK and the North Star clinician also met and say, okay, what do we think? Based on the data that we have, and we do not have a full history of these children because there is a confidentiality issues when they come from different countries and different continents, what can be shared, what cannot be shared. But we reached the conclusion that there is no clear evidence that these episodes are directly related to givinostat. And other factors that might be other concomitant medication or comorbidities might have played a role. I don't want that this is interpreted like there is no connection. The reality is that we do not know. Okay, there might be a connection, might not be any connection at all. I don't feel that is a direct cause, or there is no evidence that is a direct cause. But we felt comfortable to say that we need to monitor. We are not at the point to say we stop givinostat because of these 3 events, but we need to be careful about how to prescribe because there is a lot of unknown. And when there is unknown, we feel confident to take some responsibility and to share this responsibility with the families, but we also feel that we need to be cautious until we have more evidence. So the guidance became interim, and is important. We learn. We need to wait to the MHRA feedback. We need to know what happened when the NICE approved the drug or doesn't approve the drug. And we need to learn from more evidences, both from the ongoing clinical trial, but also from the real world about what is the best thing to do. And therefore, we might change. Unfortunately, we do not know everything at the moment. So take-home messages. So givinostat showed that slow down the disease progression in children with Duchenne muscular dystrophy. but has not shown an improvement in muscle strength and function. And I think that this is important in terms of managing expectation. Second, givinostat is overall well tolerated, but it doesn't mean that it does not have side effects. And the monitoring is required in order to control these side effects, which can be severe and serious, is intense. And this is important because it required compliance and tolerability. And there are some children that every blood test every 2 weeks, and even more often, because if they start to have side effects, they need more blood tests and the ECG, and they need to come back to clinic. It's too much. And it's fine. And the reality is that the evidence of givinostat are limited in terms of the time to exposure. So we have data up to 18 months of exposure, a little bit longer with the open label extension study, but actually are very limited. We don't know the very long-term effect on givinostat. And what we know about the loss of ambulation is an extrapolation that if you are able to get up from the floor for longer, you're expected to walk for longer, but it's an assumption. Okay, so we need to learn in terms of time. But we also need to know, because the data that we have are limited to young ambulant children. I can tell you that in the open label extension study, only 11 boys were enrolled in the open label extension study as non-ambulant, and therefore they were unable to, the variability of what these boys did on givinostat was too high to be even analyzed. So there is uncertainty. And we need to take that uncertainty. And uncertainty doesn't mean it works and the doctor doesn't want to prescribe it to me. But also is the uncertainty around the drug interaction, or how does it work in older children or young men who also have heart problem or breathing problem. We do not know. And therefore, we need to put safety first. And we need to monitor this patient. And the overall message for me is that the benefit for any drug, for us and for children and adults with Duchenne, the benefit risk is an individual decision. And it is important to consider that. Can be different from one patient to another, but if we lose the control of the risk-benefit, individual assessment of a risk-benefit, then we might be in trouble. And thank you to everyone who contributed to this big piece of work.